sir, can we hear you on Zoom?
Yes, ma'am.
Okay. How are we doing, guys?
Good, Senator. How are you?
Great. Well, let me thank everyone for being here today, and Dale for being in North Carolina with. I wanted to say a few words from an overview context about the high prices, outrageously high prices that Novo Nordisk is charging the American people for Ozempic and Wegovy. So I want to put it into a little bit broader context. Here's a fact that is not disputed. The people of the United States pay by far the highest prices in the world for prescription drugs. I personally, on 2 occasions, just myself, as a U.S. Senator and previously as a congressman, have led Americans into Canada, where we purchased on one occasion a breast cancer drug, tamoxifen, and on another occasion insulin, for one-tenth of the price Americans were paying for the same exact product, same exact bottle, same product. Overall, the best estimate is that we in America spend nearly three times what people in other countries pay for the exact same drug. Okay? Overall, we're spending 3 times more than what other countries are paying for the same drug. The result of this absurd reality is that while 10 top pharmaceutical companies made over $110 billion in profits last year, 1 out of 4 Americans cannot afford the medicine their doctors prescribe. Think about that for a minute. 1 out of 4 Americans can't afford the medicine their doctors prescribe. Now, how insane is that? People go to a doctor, they get a diagnosis. They go to the doctor when they're sick. They get a diagnosis, and then the doctor writes out a prescription to deal with their illness. They can't afford it. As a result, people die, and we in this country lose tens of thousands of people unnecessarily every year because of the high cost of health care in this country, including prescription drugs. All right? And incredibly, on top of the loss of human life and suffering, we end up wasting huge amounts of healthcare dollars because people who can't afford their prescription drugs end up in emergency rooms or in hospital beds for what could have been an easily preventable illness. So people are sick, and instead of getting well, they get sicker, end up in the emergency room, end up in hospitals, pain, suffering, death, and huge costs to the healthcare system. And when we understand that in America, we are spending now $13,500 for every man, woman, and child in this country, double what almost any other country spends, we also understand that one of the reasons for that outrageously high cost of healthcare has to do with the high cost of prescription drugs. So when you talk about high healthcare costs, you have to include in that very high prescription drug costs that we pay. The outrageous cost of prescription drugs in this country drives up hospitals. I talked to my local hospital. You know what he told me? 20% of their budget goes to prescription drugs. These cancer drugs, other new drugs, off the charts. And it also drives up private insurance costs. My wife and I have a very good insurance plan. We pay a fortune for it. I don't pay much for prescription drugs. We pay a fortune for private insurance. Private insurance costs up because of the high costs of prescription drugs. Further, and very importantly, the high cost of prescription drugs has a huge impact on taxpayer expenditures. in terms of what we spend on Medicare, Medicaid, and other federal programs. Our healthcare system, I think most people understand, is in crisis. The business model of the pharmaceutical industry is unsustainable from a humane perspective and from a financial perspective. We need real change, and that's what we're talking about today. Now let me get to Novo Nordisk, the manufacturer of Ozempic and Wegovy, prescription drugs that may end up being the best-selling drugs of all time. So people say, well, why are you focusing? You know, a lot of drugs out there, true. Why are you focusing on this one? These may be the best-selling drugs in the history of the pharmaceutical industry. Next week in this room, the Senate Health, Education, Labor, and Pensions Committee that I chair will be holding a hearing on the outrageously high prices Novo Nordisk is charging Americans struggling with diabetes and obesity for Ozempic and Wegovy. So we're holding a hearing in this room with the CEO of Novo Nordisk. And today I am delighted to be holding this roundtable discussion with people who have worked tirelessly on the need to substantially lower the price of these drugs and to make them available to everyone who needs them. In a few minutes, we will be hearing from Kristen, Whitney, who is a patient who was forced to ration Ozempic because she could not afford the price of the drug. We're going to hear from Dr. Rishma Ramachandran, a physician who works at a community health center in Connecticut, who will talk about what the high prices of these drugs means to her patients. We're going to hear from Dale Folwell, the treasurer of the state of North Carolina, who had to stop covering Wegovy for his state employees because of the outrageously high price. We're going to hear from Dr. Melissa Barber, an economist from Yale University, who has done extensive research on the manufacturing costs of Ozempic. How much does it actually cost to make the product? And Dr. Allison Galvani, also of Yale, who has done extensive research in determining how many thousands of lives could be saved if Wegovy and weight loss drugs were made widely available. Let us be clear. Novo Nordisk charges Americans with type 2 diabetes $969 a month for Ozempic, while the same exact drug can be purchased for just $59 in Germany, $71 in France, $122 in Denmark, and $155 in Canada. Novo Nordisk charges Americans with obesity $1,349 a month here in the United States for Wegovy, while the same product can be purchased for just $92 in the United Kingdom, $137 in Germany, $186 in Denmark, and $265 in Canada. The scientists at Novo Nordisk deserve great credit for developing these drugs that have the potential to be a real game changer for millions of Americans struggling with type 2 diabetes and obesity. And I thank them, and we all should, for their hard work in creating these drugs. But as important and groundbreaking as these drugs may be, they will not do any good for the millions of people who cannot afford them. A drug, no matter how great it may be, does not mean a thing if you cannot afford to buy the product. But not only must we be concerned about lack of access to these drugs, we have got to take a hard look at the financial implications of what happens if the prices of these drugs are not substantially reduced. Bottom line, if half of the adults in our country with obesity took Wegovy and the other new weight loss drugs like Zepbound, which is produced by Eli Lilly, the cost would be astronomical and have a devastating financial impact on our country and on federal and state budgets. The best estimate that I have seen suggests that if half of the adults in our country took these weight loss drugs, it would cost $411 billion per year. My friends, that is $5 billion more than what Americans spent on all prescription drugs at the pharmacy counter in 2022 for one set of drugs. In other words, the outrageously high cost of these drugs could bankrupt Medicare while radically increasing insurance premiums to absolutely unaffordable rates. The Health Committee, Health Education, Labor Pension Committee, has heard concerns from across the country about the financial impact. I'm going to hear more about it this morning, about the financial impact of the cost of these drugs. One of the largest health insurance companies in the country has told me that they would have to double premiums for all of their policy holders if they covered Wegovy and Ozempic for all eligible patients. Think about that. You want to make it available to all? Great. Double premiums. Who's in America wants to see their premiums, which are already sky high, double? In June, the largest insurer in Michigan, Blue Cross Blue Shield, was forced to drop coverage for weight loss drugs because of the high prices. And now, let me take a moment to share something extremely important with you that I have learned over the last couple of months. And that is that the outrageously high prices that we are paying for Ozempic and Wegovy do not have to be. They are not based on the cost of production or the establishment of a fair rate of return for Novo Nordisk's research and development. They are based on nothing less than excessive corporate greed. So let me tell you what I've been doing. The last several months, I and my staff have had a series of conversations with the CEOs of major generic pharmaceutical companies. These are large companies that today supply hundreds of millions of prescriptions to tens of millions of Americans. Big companies. And what the CEOs of these generic companies have told me is something of enormous consequence. They have studied the matter, and they tell me that they can sell a generic version of Ozempic, the exact same drug that Novo Nordisk is manufacturing, to Americans for less than $100 a month. $100 a month. Novo Nordisk charges us $969 a month. These generic companies can sell this product for less than $100 a month, less than 10%. Less than 10% of what Americans are currently paying. So let me summarize and conclude, and I'm going to open up this discussion. Novo Nordisk, which has made nearly $50 billion in sales off of Ozempic and Wegovy, charges Americans the highest prices in the world for their products, in some cases 10 times more than what they charge people in other countries. The result is that millions of Americans with diabetes and obesity will not be able to afford these life-saving products. Some will die. Medicare could literally go bankrupt if it were forced to pay the prices Novo Nordisk is asking. And insurance rates that are so very high today for Americans could double if these weight loss drugs were covered for everyone who needs them. And now we learn that major and well-established generic pharmaceutical companies could sell these products in America for less than 10% of what Novo Nordisk is charging us. A few months ago in July, President Biden and I co-authored an op-ed that appeared in USA Today. And this is what we said, the President and I said in that op-ed, quote, "If Novo Nordisk and other pharmaceutical companies refuse to substantially lower prescription drug prices in our country and end their greed, we will do everything within our power to end it for them." End of quote. That's President Biden and myself. And what we said in that op-ed is exactly right. I look forward to hearing from the CEO of Novo Nordisk, Mr. Lars Jorgensen, next week as to how he will substantially lower the prices of Ozempic and Wegovy in the United States. And now I'm delighted to open up this discussion to our distinguished panelists. And again, I thank them and Dale for being with us this morning. First, let me turn to Kristen Whitney Daniels, who is a patient advocate with T1 International. Kristen, the floor is yours. Maybe 5 minutes or less.
Thank you, Senator Sanders. As Senator Sanders said, my name is Kristen Whitney Daniels. I'm a longtime advocate for T1 International. I started there because of my own rationing experience with insulin. I've been there since 2019, started the Connecticut Insulin for All chapter, and am now part of the federal working group, which I think this is an important note. We don't accept any pharma or industry money that would influence our voices. Back in 2021, I was prescribed Ozempic for control of my diabetes by my endocrinologist at Yale. I was really interested in doing it at that point. I hadn't reached the same sort of media zeitgeist that we are in right now with this, but I was interested because I knew it could potentially provide some really great benefits for my diabetes control, lowering my blood sugars, lowering my insulin intake. And also had known that there was a possibility for really great heart benefits, which my father, who also had diabetes, died 3 months earlier from heart complications. So this medication was really important to me and to my care. And for the next 2 years, the benefits continued to roll in for me. My cholesterol was down, my triglycerides were down, it helped control my PCOS. All of these benefits I never even knew that I would see. Then fast forward to 2023, when my insurance said that they were now dropping me from coverage. I had been approved for 2 years under the same coverage. Nothing had changed. My diagnoses hadn't changed. But what had changed is more and more people were being prescribed this medication, and they had to tighten the control of who could and could not receive it. And for me, that set out a domino effect. I started rationing my Ozempic, knowing that I was up against a fight against a very large insurance company who had a lot of time and a lot of resources that I didn't. And so I started rationing, hoping that I would beat out the time clock on it. And so I started appeal after appeal. After doing a little bit of numbers crunching, I spent over 60 hours on the phone and over 100 emails getting them to appeal this decision. It took 4 months and getting a state agency involved, but they eventually did. And I think it was just because I wouldn't let it go at the end of the day. But there are so many people out there who do not have the time, who do not have the resources to make that happen. But I also know this playbook, and I know it intimately, because it's the same playbook that happened back in 2016 when I started rationing my insulin. Novo, which is also by the same manufacturer that makes Wegovy and Ozempic, Novo Nordisk. And I called their patient lines, I called my insurance companies, I called everywhere trying to get assistance. And once again, when I was rationing insulin, when I was at the bottom of a wastebasket looking for used vials of insulin, hoping that I could find a few drops to make it to the next day, the help never came from the insulin manufacturer, it never came from Novo Nordisk, it came from a 340B program at a federally qualified health center. And so the government is literally the only reason why I'm alive today. I think this drug is so important, and it really has changed diabetes care for so many people, and it will continue to see benefits in different areas. But we are once again seeing a two-tier system playing out where the haves and have-nots are divided greatly. And so the people who can afford it, the people who do have insurance that can cover it, will have these greater benefits. We know that diabetes today is a much different disease than it was even decades ago, that if you have the correct treatment, if you have affordable treatment, you can live a long life with it. But that's if you have money, that's if you have time, if you have access, if you have a job that gives you good health insurance. And all those are too many ifs, ands, and buts of things that could go wrong on any given day. And so I really thank Senator Sanders and the whole health committee for bringing Novo Nordisk to answer for these exorbitant charges that are, again, taking a page-by-page playbook out of insulin and the rationing experience. We see a monopoly happening again. Eli Lilly is also another company that has GLP-1s, which has also been one of big three insulin manufacturers in the United States. And so we need to sort of nip this in the bud. We've seen what can happen. We've seen that we can reduce the prices of what patients are paying for insulin. And I would love to see that happen again with Ozempic and Wegovy.
Kristen, thank you very much, not only for being here, but for your advocacy and for your fighting for justice in this issue. Now we're going to hear from Dr. Rishma Ramachandran, who is a physician working in a community health center in Connecticut. Doctor, thanks for being with us.
Thank you so much, Senator Sanders, for bringing us here today for this important conversation. My name is Rishma Ramachandran, and I'm an assistant professor of medicine at Yale. I'm also a national leader with the organization Doctors for America, which brings together over 27,000 physicians and trainees to advocate on behalf of patients instead of profits in our profession. More importantly, I'm a primary care physician at a federally qualified health center in New Haven, Connecticut, where I mostly take care of patients who are underserved. I think every doctor has a story of a patient or patients that haunts them. And for me, one of those patients is Mary. Mary is a patient of mine that I've had for quite some time who struggled with obesity. And over time, she developed other associated health conditions, primarily heart conditions, including high cholesterol and high blood pressure. She tried everything, and I worked with her to see if we could use strategies such as enrolling to an exercise program, being referred to a dietitian, being able to be seen at a weight loss clinic by a specialist to see if that might help her lose the weight. But unfortunately, her weight didn't really change. And she developed some pretty serious arthritis of her knees that required surgery. Now, her surgeon didn't want to proceed unless Mary lost some weight to actually ensure that she'd be safe under anesthesia during the procedure. And so around this time, Wegovy actually had been approved by the FDA for weight loss. So I prescribed this for her. She began to lose weight, and it had some added second benefits, including lowering her blood pressure, helping with her sleep apnea, and also even alleviating some of the pain from her knee arthritis. Seeing the results of this weight loss, she was booked for surgery. It was going to happen in a few months' time. But soon we began to experience various roadblocks to access to this medication that had been life-changing for her. First, it was shortages. Both she and I would call around to local pharmacies to try to find a place that would have enough supply and doses that she'd be able to access. We spent hours on the phone asking pharmacists if they might have this, but oftentimes she'd go weeks at a time without having her next dose. Then her insurance company started restricted coverage of medicine due to concerns around the cost. And she was ineligible based on the new guidelines they had set forward for coverage. I worked with her to try to call the insurance company, completed form after form, sent multiple letters of appeal in hoping to get this denial overturned. While this was happening, unfortunately, Mary regained the weight that she lost, and her arthritis actually got worse. Her surgery was canceled, and unfortunately she had a pretty bad fall, resulting in a fracture and being hospitalized. All of this could have been prevented if Novo Nordisk had priced their drug affordably with patients like Mary in mind as a priority and not their shareholders. Instead, they chose to set a price based on profits. Mary is one of many of my patients that I have taken care of who have faced access challenges due to the egregious high prices set by companies like Novo Nordisk and Eli Lilly. Some of our patients have turned to unregulated compounded versions of these drugs that have significant risks or may not just work. Most of my patients, however, can't even afford these options. And these drugs set at these prices by Novo Nordisk and Eli Lilly have only worsened existing health disparities. A Kaiser Permanente study that was published earlier this year, looking across 6 health systems and almost 700,000 patients, found that all racial and ethnic groups were less likely to be able to access a GLP-1, these novel medications for diabetes and for obesity, compared to white patients. You're right, Senator Sanders. I am sick and tired of companies like Novo Nordisk and Eli Lilly ripping our patients off. This is why I and 250 of my colleagues sent a letter yesterday to you and the rest of the Senate Health Committee asking for the federal government to step in and take action to provide my patients an affordable option. As we wrote in our letter, even the most transformative treatments will not help our patients if they can't afford them. We're heartened to hear that there's steps being taken forward and some commitments from generic pharmaceutical companies to be able to produce an affordable option for our patients to prevent instances like what happened to Mary happen ever again. Thank you so much.
Thank you. Thank you very much, Doctor, for all that you're doing fighting for your patients and patients all over the country. And now we're going to go virtual here. We're going to go to North Carolina. We're going to turn to Dale Folwell. Mr. Folwell is the treasurer of the state of North Carolina. And he is going to discuss with us his experience dealing with Novo Nordisk. Treasurer Folwell, thanks so much for being with us.
Thank you, Senator Sanders, for making this jump up on the table. I'm going to discuss why and how, just very briefly. Number one, I'm wearing a lapel pin today that has NC on it. That normally stands for nothing compares in terms of North Carolina's economic strength, but it also says nothing compares as far as the high healthcare and prescription drug costs that we're facing in North Carolina, especially on behalf of those that teach, protect, and otherwise serve, who are state employees, who make their living with their hands, their back, and their feet. I want to start in our state, but the fact is that we are under siege. At the end of the day, our state health plan board had to make the awful decision to stop covering Wegovy. We take obesity, the disease of obesity, very seriously. This same board nearly 6 years ago eliminated the cost of insulin for those that teach, protect, and serve. So they have had their finger on the pulse of things that are going on with insulin adherence and obesity for a long period of time. Be clear, Senator Sanders and others that are on the call, to put this in context. This came up on the table very quickly. We had 23,000 users of Wegovy on the state health plan, which had the potential of costing nearly $170 million a year. To put that in context, Senator, we have nearly 250,000 retirees on the state health plan. A 4% bonus to those individuals is also about over $100 million. So we have one drug that's consumed by just 10% of our an equivalent to the number of people who are retirees. One drug costing the equivalent of nearly a 4% bonus. That's why we had to make the decision, because our plan is insolvent. At the end of the day, I'm on this call thanks to CNIC, State Employees Association, and President Kirk Montgomery and Ernest Watkins. And I appreciate them setting this up. When I talked to Senator Sanders a few months ago, he said, "Why is this so important to you?" And the reason is the blood that runs through me is Quaker. And one of the spices of the Quaker religion is to be fair and just. And what that means is doing right's rarely wrong. And once we see something, we can't unsee it. This is not a Republican, Democrat, unaffiliated libertarian issue. This is a moral issue when people cannot afford the drug that they need to take advantage of this. I've also said repeatedly, we've never questioned the efficacy of this drug. We're simply questioning what we're having to pay for it. Senator Sanders, to your point, if we had continued to cover Wegovy in the state health plan, we would have had to double the individual premiums on our state employees, double those premiums, and that's mathematically correct. This is not emotional, it's not political for us, it's simply mathematical. I applaud any effort that's being taken to make this generic as quickly as possible so that we can start covering this. Medicaid in North Carolina has started covering this drug, and I've asked them what they're paying for it. and no one will tell me what they're paying for it. But we're still delving into that. But a couple of things have been mentioned about 340B programs already. Our office did a report about how cancer drugs for the state health plan on behalf of those that teach, protect, and otherwise serve. Some of these hospitals are buying these cancer drugs for $500 a dose and charging $600 a dose and charging us $6,000 a dose for under the 340B program. As far as the how, very quickly, just to say that it's reported by our staff internally that 2% of the United States sales of Wegovy, this is a few months ago, 2% was being prescribed out of the North Carolina State Health Plan. That gives you a mathematical reason why we're under siege. As far as the other issues are concerned, I want to close my remarks by thanking Senator Sanders and anybody else who's willing to work for this. The second thing that Senator Sanders asked me a few months ago is, now I know why this is important to you. Are you sure you want to be talking to me? And I want to remind people of the meaning of words. The root word of conservative is to conserve. That's what I am. And the root word of liberal is to liberate, to set economically free. When people cannot afford these prescription drugs, then they're not conserving, and they can never be economically free to get the joy of achievement and the upward mobility in their life. And this is not about what something it costs. It's about also what the price is to the average people. I also want to say this, that anybody at any level of government, state, local, or federal, who's unwilling to talk to anyone else about actually how to solve a problem that's facing the people of this country or our state, if they can't talk to anyone about how to actually solve a problem, they should resign their offices, because this is such an important issue. So as I close, I just want to thank you for having me to repeat that our state health plan was under siege, and that's why we had to stop covering this on behalf of those that teach, protect, and serve. And when you go in your hearing next week, Senator Sanders, on the Lester Holt show a few weeks ago, the CEO that was being interviewed was asked about the fact that I have referred to this as a cartel. A cartel are associations which are formed to restrict competition or raise prices. And in that interview, and I hope you'll ask him about this, he said some people can buy this for $25. Where? How? Because we will start buying this drug for $25 on behalf of those that teach, protect, and serve. The only number that I've ever heard close to the number of $25 is the cost of manufacturing it. So thank you for having me.
Well, Treasurer Falwell, thank you very much. The Treasurer has shown a lot of courage. Not every public official in this country who does the work that he does has had the willingness to stand up.
For his constituents. So I thank Dale Falwell very much for his work and for being with us today. Next, I'd like to go to Dr. Melissa Barra, who has done extensive research on this entire subject, and it was a healthcare economist. She's an economist at Yale. Dr. Barra, thanks for being with us.
Thank you very much. I am a health economist. I research pharmaceutical production and markets. I completed my PhD at Harvard University, and I'm currently a postdoc at Yale. About 2 years ago, I began a research project analyzing the cost of manufacturing GLP-1s and other medicines for treating diabetes. The results were published in March in JAMA Network Open. We show that semaglutide, today we're talking about Ozempic and Wegovy, but semaglutide is the generic name, can be profitably manufactured for just under $5 per month. So, how do we arrive at this cost? To briefly summarize our methods, first, we estimate the cost of the active pharmaceutical ingredient, or API. This is the part of the medicine that has therapeutic effect. To do this, we analyze real-world data of transactions among manufacturers and corroborate these estimates in interviews. Next, we add the cost of excipients, or the non-therapeutic ingredients in medicines, and for which bulk prices are readily available. Then, we add the cost of the injection device, and then overhead costs, So that's the cost of running the facility. Finally, we add taxes and a markup. So we have a lower bound and an upper bound estimate. At the lower bound, we assume a 10% markup, and for the higher bound, it's a 50% markup. So that the $5 a month is the upper bound. That's a 50% markup. So that's quite a chasm between the current prices of around $1,000 a month and our estimates of about $5 per month. Some folks have been a bit surprised. So why should you believe me that generic treatment for under $5 per month is feasible and even profitable? First, cost of production estimates are useful, but they're not exactly rocket science. Companies conduct these analyses every single day in deciding whether or not they should enter a given market. The only thing unusual about our estimates is that they're in the public domain. Second, I have an established body of work in drug costing. In 2017, I was commissioned by the World Health Organization to develop methods for estimating drug production costs. In the years since, together with colleagues, I've estimated the cost of production for hundreds of drugs, the results of which have been published in reputable peer-reviewed journals. Finally, our estimates had a good track record for being right. As one example, we estimated the cost of production for insulin glargine pens to be about between $1.16 and just under $5. So there was a US Senate inquiry, I believe, and as part of that, Sanofi turned in documents that listed their cost of production, and they disclosed it was about $1.42, so right down where we were estimating. As a second example, we estimated the cost for hepatitis C drugs would fall from about $84,000 when they arrived on the market to $32. Today, you can buy those drugs for $34. Our cost estimates for HIV and tuberculosis drugs have similarly proved accurate once generics entered the market. The current situation is not sustainable. These markets cannot be justified, and as we've heard from the other speakers, are hurting patients. Drug markets are not a zero-sum game. Novo Nordisk and Eli Lilly have said time and time again that they don't even have enough production capacity to meet demand. Today, we are focusing on GLP-1 access in the United States, but I briefly want to note that the situation globally is so much worse. I conducted this study alongside Doctors Without Borders, who in their operations treating patients around the world have not yet used GLP-1s, despite the clinical benefit they would provide for many of their patients, because Novo and Lilly aren't selling these drugs in most low and middle income countries at any price. And globally, the prices are set, so it's difficult to import at an affordable price. And at the same time, these companies are blocking generic competitors from being able to increase global supply and lower prices. Locking these drugs up into just two companies is also having knock-on effects on insulin access. When production capacity is fixed, companies will pivot production lines to their most profitable products. In this case, from insulin to GLP-1s. This is not a hypothetical. Novo Nordisk has said that they are exiting the human insulin pen market, and a few months ago, they abruptly stopped supplying human insulin to the South African public health system. The present situation of artificial supply scarcity and astronomical prices serves no one but Novo and Lilly's CEO and shareholders. These drugs were developed with public investments, can be manufactured affordably, and should be available to the public on reasonable terms. Thank you.
Dr. Barbara, thank you very much. And now we're going to go to Dr. Allison Galvani, the founding director of the Yale Center for Infectious Disease Modeling and Analysis, and a professor of epidemiology at the Yale School of Public Health. Dr. Galvani, thanks very much for being with us.
Thank you, Senator Sanders. Thank you, Senator Sanders, for bringing awareness to this pressing challenge and for the opportunity to share our research today. But the work has been simultaneously both exciting and disheartening. It's exciting because these GLP-1 medications represent a paradigm shift in the safe and effective treatment of diabetes and obesity. Obesity is a pervasive epidemic affecting 4 in 10 people. It acts as a silent killer, increasing inflammation in the body and exacerbating a multitude of causes, including cardiovascular disease, cancer, and type 2 diabetes. It's also a major risk factor for infectious diseases like flu and COVID. While it's rarely listed as the primary cause of death, the elevated mortality associated with high BMI means that obesity accounts for hundreds of thousands of preventable deaths in this country. And this underscores the disheartening aspect of the work. The majority of these preventable deaths are not being prevented. Exorbitant costs and inadequate insurance leave people without access. The manufacturers should be applauded for these innovations. However, when the prices they charge make them inaccessible for most, it only widens the gap between the haves and the have-nots, further entrenching health inequities. This gap is particularly alarming given the disproportionate burden of these diseases among economically disadvantaged populations. It's a tragic irony that the people who need these medications the most are the least able to access them. In our research, we've estimated the lives that could be saved by expanding access. To do so, we've analyzed several sources of key data quantifying how someone with a high BMI is more likely to die within a given year. We've also incorporated the population distribution of BMI levels in the US to determine how many people whose life expectancy could be extended by these medications. Accounting for realistic adherence and the efficacy of the medications, we've been able to estimate both the current and the potential impact. Our results show that about 8,000 lives are currently being saved. However, if we extended access to everyone who is eligible, an additional 32,000 lives could be saved. Our results highlight the urgency of addressing access barriers, including affordability and insurance coverage. These medications could dramatically improve public health, save lives, enhance the quality of those lives, lower associated medical costs, and boost worker productivity. By implementing policies that ensure broader access, we have the potential to galvanize a new era of American well-being and prosperity. Thank you, Senator Sanders, for your leadership in realizing this potential.
Dr. Galvani, thanks very much for your important work. What I want to do now is ask a very simple question to each of our panelists, and that is what Dr. Barber has told us is if we wanted to be very, very liberal and generous, and we would estimate that Novo Nordisk could make a very generous profit selling the product at $5 a month. Is that what I heard you say?
Yes.
All right. $5 a month. So let us be very, very liberal here. We're going to give them $50 or $100 a month. Okay, how's that? What would that mean, Kristen, in the world that you live in as an advocate for patients who are having a hard time accessing this drug? If the drug were now $50 or $100 a month, what would it mean to those people?
It really could mean the difference between making choices. I mean, for me, I've had to make choices about going back to college. Some people have to worry about food and car payments and insurance and all of these other concerns. And for me, I, at one point, debated going up to Canada to go get my Ozempic. And I couldn't go because they had banned Americans from purchasing Ozempic because they had such a shortage there. And this would actually be less than I was quoted to go to Canada. And so, I mean, it would be an access and affordability issue for all of us.
Thank you. Dr. Ramachandran, what would it mean for your patients if this product were $50 or $100 a month?
this would be transformative for all my patients. I have several patients who have, even when I prescribe Ozempic or Wegovy, it's not an option for them to be able to pick it up at the pharmacy counter. Or, as Kristen mentioned, they're rationing other medicines or other expenses to be able to afford this. We already know also that about half of patients who take Ozempic who have insurance report difficulty affording the medication. So even for those patients, having ability to be able to access a more affordable option would change their whole economic future, their whole health perspective, and also allow them to reap the benefits from a health perspective of these medications. It would have a huge impact, especially on health disparities. As I mentioned before, we know that patients who are Black and Hispanic, even Asian, American Indian, are not able to access GLP-1s compared to those who are white across this country. And at that price point, we would see dramatic shifts in those disparities and a step towards health equity in those medicines.
Thank you very much. Treasurer Folwell, what would $50 or $100 a month product mean to the well-being of state employees in North Carolina and to your state budget?
It would be Senator Sanders, and what we have now is a drug tax. Conservatives are typically not in favor of taxes, but what we're seeing now with the price that state employees were having to, our plan was having to pay, was a drug tax, and it would mean everything if that were to occur. And put this in context, we manage about $250 billion at the Treasurer's office. That's 8 times larger than the state budget. The stock market value of Novo Nordisk, it's reported, is twice as high as the gross domestic product of the entire country that they're headquartered in. The stock market value is higher, twice as high as the gross domestic product of Denmark. And finally, Senator Sanders, as you look to actually solve this problem and get people to the table, every suggestion we've sent to Novo Nordisk and our PBM to try to lower this cost, every one of those has been rejected. And all this has to be done looking out the fact that this drug will eventually become oral and not in these vials that I'm showing right here. And so whatever problem we're talking about could get even more costly. I know this because as a state treasurer, I approved nearly $180 million worth of water treatment plant for Johnston County, where Novo Nordisk has a big exposure. They use about 33% of the water and sewer in that county. So when this drug becomes oral, the prescriptions are going to go through the roof.
Once again, Treasurer Folwell, thank you very much for your important work. Dr. Barber, what, from your point of view, would lowering the cost of these drugs substantially mean?
I think I'm not as well placed as some of the other people on the panel to talk about the effects on patients. So I guess I'm stuck playing devil's advocate and talking about the effects on global markets, which is to say, Novo Nordisk and Eli Lilly are going to be just fine. I would still anticipate them to have among the highest profits of any drug company in the world this year, even if prices were reduced to that. I did a back-of-the-envelope calculation a few weeks ago, and if CMS continues paying the prices that they're paying now for the number of patients they're scheduled to pay, it would be cheaper for CMS to just buy Novo Nordisk than it would be to pay what we're paying just over the next 2 years. We break even in 2 years. So, I mean, I don't know, right? $50 to $100 will still give Novo Nordisk a very, very, very tiny profit margin. The shareholders need not fear. It's going to be okay, and yet we can still transform access to treatment both in the United States and globally. Thank you.
Okay. And Dr. Galvani, this is obviously the issue that you have focused on, what increased access would mean in saving lives. Why don't you summarize your findings again?
It would have a transformative impact on public health. As I mentioned, saving tens of thousands of lives. In fact, this class of medication could save more lives than any other class of medication that's currently available. And that would be, I would think, an achievement that the manufacturers should be extremely proud of. And in addition to saving, our calculations have focused on saving lives, but it's conservative in a number of ways, including the morbidity associated with obesity that causes higher severity of other diseases associated with morbidity, loss of work days. So there are a number of ramifications for people's quality of life and the prosperity of the economy overall.
Okay, well, let me very much thank everybody who's here and Treasurer Folwell. This is an issue, as you have heard, of unbelievable consequence. We're hearing a suggestion that this could be a game changer in terms of saving lives, improving the quality of life for millions and millions of people, in saving healthcare dollars. We are spending a fortune, twice as much as any other country, on healthcare. Obesity is one of the factors, diabetes, huge expenditure, and we got a real handle on it. So the question that we are dealing with is, do we save lives? Do we improve lives? Do we save money? Or do we continue to allow a handful of very, very profitable corporations continue to make outrageous amounts of money? That's a challenge that we face. And as Kristen mentioned, this is a life and death issue. Life and death issue, as the Treasurer mentioned, this has a huge impact on people's taxes, state budgets. So this is an issue we are going to pursue, and I just want to thank everybody for the great work that you're doing, and I look forward to seeing the CEO of Novo Nordisk, Mr. Jorgensen, at this table next Thursday. Thank you all very much.
Thank you, Senator Sanders.
Thank you very much.
And be sure when he said $25, I'm first in line.